Okay. All right. Good morning, everyone. I'll give everyone a second to get seated. It is so wonderful to see all of you in person. Whew. My name is Hwang. I'm in the office here at Diagnoses campus. I'm so excited to welcome all of you in person as well as those joining virtually. I know we have several in-person attendee registrants who had to convert to virtual last minute, but I still hope that this hybrid format allows both flexibility but also quality of engagement. I'm so excited for today. I'm actually really nervous. I'm going to see you all in person. Acknowledge this. Rebecca is out there. Rebecca, I have to acknowledge Rebecca Dooley, who has this as seamless as possible. Even as of yesterday, she is emailing me about running to the FedEx office and fixing various things, and she's really made this happen. And I'm so thankful. Also thankful to Olivia from CPCPC and Blair Lightbulb. This event is sponsored by our School of Medicine section of Neonatology and Colorado County Care Quality Collaborative. Very, very thankful for their support. Quick note about the nights. Because it is a hybrid format, those that are participating by Zoom will not be able to hear your comments and questions unless you use the mic. You have to turn it on and speak into it. There are a couple I've been told that are not working, so if it says that working doesn't turn on, you can just say your question, let me know your mic is not working, and then I will say your question through some other mobile mics so that those that are participating from home will hear your question. All right, so let's get started. So this question, why are you here? Why am I here? This is not an existential question of why do you exist, but why are we here talking about family and the community? I can assure you that for all of you, when you were 7, 8, 9 years old, and someone asked you, what do you want to do in the world? It was not to be a champion for community, I'm sure. For myself, as a physician that has been training for quite some time, when someone asks me, what do you want to specialize in and why? I eventually got to neonatology, but it was not to ensure that we center families in the community. It was about physiology, it was about acute neonatal care, it was about prematurity. And so how did I end up here and why are you all here? And so I'd like to share with you a bit of my personal experience of why I'm interested in this work. And I hope that today offers you time and space to share your own stories and what brought you to this work. This is a picture of my family, and this is shortly after we had immigrated from Korea. My family left Korea when I was 5 years old. We arrived here for speaking no English, undocumented. We had very little when we came. And we came with very little. And there were systems, structures, community organizations, friends and families that existed, that surrounded us so that we could thrive. And there were so many reasons given my own nuclear family that I should not have thrived. So when we talk about adverse childhood experiences, ACEs, etc., I lived them, I embodied them, I still embody them now as an adult. But because there was so much in place around us and under us, it allowed our family to thrive such that my older brother and I are secure and stable, have a sense of well-being. Wrong dress to wear apparently for the microphone. And so
We're trying to adjust.
And so not sharing with you our immigrant story, which is a very common story of many immigrants in the United States. It's not a story about pulling ourselves up by the bootstraps because we did not have any roots. It's not a myth about the Asian model minority, because that in fact is a myth. What it is a story about is how systems and structures were put into place so that families such as my family had an opportunity to thrive when we had so little. And so I come here today with an interesting family engagement in the NICU because there's so many families We cannot expect them to do it all on their own. It is not fair, it is not just. There are so many forces external to their nuclear family that sets them up for failure. And so it is essential for people like us, and maybe so many more people, to recognize that and to actively intervene and address and support. So think about, why are you here? And please share throughout the day. All right, let's move on to the work. And we all have different definitions of what we think family engagement is. And I think we all, by default, know what it is, but how do we put language around it? There's no official definition. This is one that we've been using at the time. So family engagement, a set of behaviors like patients, family members, and health professionals, and a set of organizational policies and procedures that foster both the inclusion of patients and family members as active participants, members of the healthcare team, and collaborative partners with providers and provider organizations. I love this definition because there are individual level, organizational level, systems level actors, programs, and policies that are considered for family engagements. Now, family engagement is absolutely a movement, and we in Colorado are in the center of it. I'm so excited for this work. And so, much like family engagement in the NICU, it's really parallels how we think about the role of patients and parents in healthcare in general, right? So we shifted from paternalism, where healthcare professionals were seen as the expert to act upon patients and families. We then moved on to patient-centered care, where patients and parents are placed at the center, and we sort of revolve, we being healthcare providers, revolve around it. Now we're really trying to achieve partnership of care, where families are in the circle of decision makers. They are not external, internal, they are part of the team, and that is the goal. We know that parents are amazing champions and advocates, passionate, active agents that have a personal stake in safety, care experiences, and harm prevention. And many parents and families initially may not have the skill set to advocate effectively, but so many are willing to learn, engage, and learn about new ideas to improve the care of their babies, but oftentimes of the population of NICU babies, which is what I find so inspiring. And parents influence and inspire action in others, and today we will hear about how inspiring parents can be. And we know that there is now a growing body of very robust literature that shows us that greater parent engagement leads to better outcomes for the baby and the family. So, shown here is our define key driver diagram. And it's not meant for you to digest all today. You can go home and ruminate about it. But I want to highlight that there are 4 primary drivers that we're focused on for this effort. Communication, social determinants of health, so identifying and then intervening upon social and financial supports for families, family engagement and hands-on NICU care, and family participation in discharge planning. Critical to this is that our primary outcomes are parent reported. So our primary outcomes are improving parental report of engagement in infant health and development by 20%, reducing disparities in parental reported engagement by race, ethnicity, primary language, and distance from the hospital by 20%. So this is unique in that there are very few statewide quality collaboratives that focus on parent report as the primary outcomes. The reason being, everybody says it's so hard to collect data. We're never going to get good data. And our answer was, we have to try. Because the family experience at this point is not well collected and not well represented in our electronic medical records and our birth certificates. Think about all the usual data sources that we use for quality. Where do you really see parent experience? It's not there at present. So we have to use their report as the primary outcomes. I'm thrilled to say that we actually have data. So it's many years in the making. If you all remember, our first meeting with Define was in person, and then came COVID. We met virtually for 2.5 years. We were working on the data system that whole time, and now we finally have some data to share. And so moving forward for all of these semi-annual meetings, I will always present a data update to open up our meeting. I'd like to give a shout out to the 6 hospitals that are participating in Define at present and contributing data to the data system. We've got Children's Hospital Colorado here at Anschutz, down in Colorado Springs, Denver Health, St. Joseph's Hospital, UCH Highlands Ranch Hospital, and then our University of Colorado Hospital here on campus. So, as you may recall, we engage families shortly after admission. We do the first parent survey shortly after admission. The second survey is done close to discharge, and the third survey is done about a month after discharge. In addition to the longitudinal prospective parent surveys, we do have some chart abstraction that medical teams are performing. So you can see here amongst these 6 facilities, we have 229 families that were enrolled. Chart abstracted data completed 41%. So I'll just highlight, I recognize there's a bandwidth issue in your units. I'm sure your units are busted at the seams just like ours, but there is a bit of a lag in the chart abstracted data elements. So for that first survey, we had about 64% of families that completed that first survey. Some went home. There were some who were transferred and one who died. 159 were eligible for follow-up, and then we had 39% that completed that survey around the time of discharge, and then 28% that completed that 1-month follow-up survey. So you can see that the follow-up really does drop off. And that's something that we really have to think about if we want to get better data. We can share with you some limited demographic information. So you can see here that amongst enrolled families, 87%, I think the bottom part is cut off, which is very unfortunate. So you can't tell what color stands for what. But the sky blue are mothers, so about 90% of the enrolled parents are mothers. Infant sex, we have about a slight higher percentage of males who are enrolled. Here are the diagnoses for infants who are in the NICU. The majority are prematurity, and then you have a smattering of others. These do overlap, they're not exclusive of each other, but I will highlight that while we are focused on prematurity, we also have to think about our full-term infants who have medical complications, who also have prolonged hospital stays in the NICU. Most recently, when I was publicizing our Define effort on Twitter, the group called Hope for HIE, hypoxic encephalopathy, reached out to me and said, well, what about those families who are not impacted necessarily by prematurity, but other complications like HIE? How can we get involved? And so I'll be meeting with that organization in the near future. For language spoken at home, we have the majority, close to 90%, who speak English at home. We've got some Spanish speakers, about 5% both, and then 3% other. We have infant insurance. So a little more than half are privately insured, and the remainder are public or other. Now, you might ask, well, why is this important? It becomes really important when you think about what services and supports are available to these families after discharge. How are they going to be supported? Because sadly, insurance matters. In addition, we know that for families who have to get relocated to a higher level of care, in order for their baby to be back transported closer to home after they recover from that acute illness, insurance absolutely matters. Who's willing to pay for that back transport? Here we have race of parents and the infants. So the top shows parent reported race. So this is from the parent surveys. In purple is the infants, and then the blue is parent. The bottom is what's chart abstracted. So this is what we, the healthcare providers on the team are likely pulling from Epic to know that infants race. The first thing I'll highlight is it's different, right? Parent report and what's pulled from EMR. Second point that I'll make is that infant race and parent race are not always the same. In addition, EMR at the bottom does not represent the heterogeneity of our NICU population as family reports it. So those are 3 really critical points if we're actually focused on equity, racial ethnic equity. I can tell you that I'm a Korean American, I clearly look very Asian. I'm married to a white man. My children look white. They navigate the world in a very, very different way than I navigated the world when I was their age. And so while I call them biracial, they consider themselves, there it is, biracial. Their lived experience is actually quite different. And so while we think this is just semantics, this is actually really important. Parent-reported ethnicity, similar conclusions. So infant and parent, some differences in Hispanic ethnicity as parents report for themselves and for the infant, and then certainly differences compared to what's chart abstracting. Here we have how families get to the baby. The majority use their personal car. We have a smattering of other ways of transportation. For the majority of our families, this is shown on the right, 56%, it takes them less than half an hour to get to the unit. We have about a third where it takes them 30 to 60 minutes. And then we have a little more than 10% where it takes them anywhere from 1 hour to more than 2 hours. So think about that as a barrier to family engagement. So now I'm going to share a few data points from each of the key drivers. The first key driver is communication. Our data elements that we are focused on for this key driver is parental report with communication and family updates. So this question asks, how much effort has been made to help you understand your infant's health issues? The scales from 0 to 4, 0 being no effort, and 4 being every effort. And you can see across the quarter, since we started collecting data, scores are quite high, ranging from mid-3s close to 4. The upper graph is response at enrollment, so this is around the time 2 to 4 weeks after admission, and the bottom are responses pre-discharge. That being said, there is a bit of a downward slope, right, as the time has gone on. And certainly, if you think about that response pre-discharge, that last data point was 3.3. That's around the time of discharge. And, that should really be a 4. That family fully understands everything about their infant's health. So again, these are relatively small numbers that we'll have to follow over time, and certainly really important to look at your local data and understand what's happening locally. Next, have you had enough input in your infant's care? Scale of 0 to 3, 0 being no involvement, and then 3, yes, we definitely. Again, the upper graph is response at enrollment, bottom is response pre-discharge. So, we're ranging anywhere from 2.5 to about 3, so overall pretty high. But think about this is just averages. So there are families who are still saying yes, maybe a number of 2, but not with confidence. So again, I think what's really important here is to do a deeper dive in your local units to understand what your families are saying about how they feel included. I love this question. How often have you felt like a parent? Clearly, these families have not had a normal learning experience. Their babies are not home with them, but they're in the NICU. And amazingly, many families report very high scores of 4s and 5s, most of the time and always. I think that's great. Key driver number 2, focus on services and social supports. And so we ask families on a scale, how often are you feeling worried or stressed about these various items, these various social determinants, other factors, competing priorities, etc. So this is the prevalence estimate of families who report always or often. The sky blue is at the time of enrollment, the red is just before discharge. The first point I'll make is these numbers are very high. Right, so we have over a third of families expressing stress and worry about bills, almost a third about transportation, childcare, etc. So very high. The second point that I feel a bit more optimistic about is that the percentages get lower for NICU hospitalization. That around the time of discharge, the numbers are not nearly as high as they are early on. Now, I can't say for certain why that is, but I am hopeful that it is because we have amazing social workers, case managers, psychologists that are supporting our families during that hospitalization. Here we have some of the challenges that families are confronting while in the NICU. Again, 2 points I'll make. One is these numbers are
especially for certain items unacceptable. Food in the hospital. Why should 10% of our families be worried about food in the hospital? That's something we can do something about. Transportation, nearly 40% at the time of enrollment are worried about transportation. I'd like to highlight some work happening at Boston Medical Center. We have the division chief here from PMC, where they've arranged Uber transportation for their families, because it's so hard in that urban setting to navigate public transportation, and then parking is like an arm and a leg in Boston. So again, something that we could do something about. The other thing, second point again, the numbers go down during the hospitalization. Again, that gives me a lot of hope that we have some systems in place that are supporting our families. So now if we put all these social and financial challenges together, the top is showing the percentage that families are reporting any of these social and financial challenges at enrollment. The bottom graph is before discharge. And so these numbers are, to me, high. I think depending on who you ask, maybe different perspectives, but I do think that this is something we need to follow over time, and especially the difference between at enrollment and at discharge, and then post-discharge. The third key driver is focused on hands-on NICU care. Our data elements related to that are skin to skin and breastfeeding. So this is parental report of skin to skin of actually doing it. And then the bottom is feeling educated about skin to skin. In orange is before discharge, and then in the blue is at the time of enrollment. So numbers are really high. Breastfeeding prevalence rates in Colorado are the highest nationally, and that is true for even our preterm population. But I would say around the education piece around skin to skin, maybe there's a bit of a gap between that blue and the orange line for the bottom graph, and I'm fully educated about that. Again, I can't make too many conclusions about that, but what I can see overall is that numbers are high in our state. Now this is chart documented skin to skin. We've heard a lot of feedback about how difficult it is to get this data in your ethics systems and it's not set up to collect this data. So first of all, I say thank you for trying to find the data, and second, we've got to figure out a better way to document it. And so on the top, we have percentage of families with skin to skin by day 7 of admission. There's this really nice increase that we're seeing from 2021 to 2022. The bottom is day of first skin to skin. It's happening in that first week. So happening somewhere between day 2 and 4. Now, I wonder if you could move that to day 0 to 1. Right? So things that we can think about. Breastfeeding and planning to breastfeed. Again, numbers overall are very high. The fourth key driver, family participation in discharge planning. The data elements that we focus on here is parental readiness for discharge, safe sleep, adherence, and discharge preparation. And I'm just going to highlight a few of the data elements here. Families are asked, on a scale, I feel confident that my infant's heart and breathing are safe. So the upper graph responds at enrollment, the bottom responds prior to discharge. The scale here is 0 to 2, so you guys aren't confused. Previously it was 3 or 4. So, we anticipate that in time of enrollment, families likely aren't going to feel confident. That's why those babies are in the NICU. But I feel like close to discharge, families should feel really confident that their babies are medically safe. And while close to 2, not really consistent with 2. I feel confident that my infant is healthy and mature now. Similarly, at the time of enrollment, we expect those numbers to be lower. And then at the time of discharge, families, we would hope, feel real confident that their babies are healthy. That being said, I totally recognize that for families of preterm infants, the idea of vulnerability is really hard to let go. And so that's something that may take time. I am ready for my infants to come home. Again, I'm going to focus here on that response prior to discharge. We're very close to 2, we're feeling very confident, but clearly in order to get to a 1.8, we had some families who reported a 1, but they were somewhat ready for their baby to come home. All right, safe infant sleep. So the reason we pick safe infant sleep is that if in fact families were actively involved in discharge and understanding what they had to do at home to keep their baby safe, that safe sleep compliance at home should be fairly high. I'm sorry to say that's not the case. All right, so here we have on the left, this is parent report of what they're finding in their baby's crib, both items, and then on the right, the infant sleep position of the baby. Again, I'm sorry you can't see the key there, but the graph on the left, so the bars on the left for each item are pre-dish, around the time of enrollment. The bar on the right is around the time of discharge. And so around the time of discharge, that's what I'm going to focus on. Families are still seeing towels and bird cloths and diapers and stuffed toys and stuffed blankets, albeit at much lower percentages than when babies are first admitted. Now let's go to position, the infant sleep position. Now, going from top to bottom for each of those graphs, each of those bars, the light one is around the time of enrollment, the middle one is around the time of discharge, and the bottom is post-discharge. So if we think about how infants should be positioned, which is on the back for every sleep, is what we say, that in fact is not happening for many of our families that are at home, and they certainly aren't seeing that in the NICU around the time of discharge. So then we created an overall safe sleep kind of yes/no score. So, in order to be 100% compliant, you have to be positioned on the back with nothing unsafe in the crib, head of the bed down. And so here we're seeing what those estimates look like over time. That orange line is at the time of enrollment. We expect that to be low because these infants are sick. They're not eligible for safe sleep. The yellow is around the time of
discharge, and those numbers are 0%. So there are no babies, no family members have reported full safe sleep compliance before discharge. And then the green line is after they're home. Still really suboptimal. And I do want to highlight that preterm infants are anywhere from 2 to 4 times more likely to suffer sleep-associated death than full-term infants. And then home sleep behaviors. Again, this is parental report. This is where babies are sleeping at home. And so the majority, yes, crib sleeping, and these are not exclusive of each other. So a family can pick multiple of these, but we've got a lot of bed and mattress, car seats, blankets, pillows, and bumper pads still in the crib. So a lot of work that needs to be done. And this is really just to kind of plant the seed for the next collaborative, which I suspect will be focused on safe infant sleep in the NICU. All right, so that was a whirlwind of data, and that's only a tiny fraction of the data that we're collecting. So lots of rich data that families are sharing with us. But I also want to highlight what are the limitations of the data that we have now and where are there opportunities for improvement? The first really important piece is who are the families that don't participate in Define, right? So while you don't have to consent families to send them the surveys, you still have to notify them and say, oh, would you be willing to share your experience? Can you share your email address and phone number so we can send you these surveys? Who are the ones who say yes and who are the ones that say no? Whose voices and perspectives are not represented in the data? And I could say that in general, the data that you're seeing is probably a rosier picture of reality. And so what are some of the barriers that we need to address for all families to participate in this effort? All right, so that was a whirlwind, and we'll talk a lot about what participation in Define and next steps look like as the day goes on, but I just wanted to give you a sense of the data that's being collected so that for units that are not yet participating, you can get a sense of what's really happening with your families, but also the rich data that you will then get back on a quarterly basis for your unit. So it is really my pleasure to introduce our next speaker, Kimberly Novot. I met Kimberly for the first time at the Vermont Oxford Network meeting just a short while ago, and just feel really fortunate, so lucky that she agreed to share her experience with us. So Kimberly Novot is the founder and executive director of Saul's Light Foundation, a New Orleans-based nonprofit organization dedicated to addressing the unique social emotional needs of Louisiana's NICU and bereaved families. As an equitable healthcare advocate and birth doula, Kimberly is most passionate about maternal mental health issues, prematurity, and infant loss in the Black community. After experiencing all three, she knows that the most impactful thing we can do after loss is to lead a meaningful life. Thank you so much, Kimberly.